from Thursday before we move on to anatomy for a week. The anatomy is the blood vessel. And then our last lecture on Tuesday next week for this unit will be blood pressure. Okay? There'll be a little bit of new material when we talk about peripheral resistance, which comes from the blood vessels. And we'll also be reviewing cardiac output, contraction, stroke volume changes at blood pressure as well. So we talked a lot about the neurotransmitters. All right, so one more review on epinephrine or norepinephrine. Remember, these are the only neurotransmitters that affect both the autorhythmic cells and the ventricular contractile cells. Okay? So for heart rate, it's going to affect the pacemaker cells, the autorhythmic cells. And again, to review, it does that via the cyclic AMP production that increases the number of cutting channels that are open as well as opening them early, and increases the number of transient calcium channels that are open via the activation of protein kinases. So that's the autorhythmic cells. And then the contractile cell effect, remember when we talked about contractility, we're talking about the increase of contractile force due to calcium ions. When we talked about the factors that affect venous return, there were two factors that caused an increase in stroke volume, and one factor that caused a decrease, all right? So when talking about venous return, or not venous return so much, but talking about the movement, the stroke volume, the movement of blood out of the heart, we had preload. And preload had to do with the increased contraction force, not contractility, but the increased contraction force of the expansion of the ventricles increased. And that was Frank's starting law. That was the one I illustrated with the elastic rubber band. So if we stretched the elastic rubber band out a little bit, it came back to the same relaxed diameter. And if we stretched it out a lot, it still came back to the same relaxed diameter. So it contracted more to come back to its original relaxed diameter. Okay? So the stretching of the ventricles, that increases the returning contraction back to the normal relaxation, is preload and Frank's starting law. And preload, we talked about in diastolic volume as being a homologous term. And we talked about venous return. Anything that increases venous return is going to increase preload, okay, because it's going to increase in diastolic volume. And then we talked about contractility. And this may be confusing at first because both of them is an increase in contraction. But contractility has to do with calcium ions, all right? So we can have no additional preload and yet have a greater force of contraction if we have more calcium ions in the contractile cells, just because more binding sites are made available for myosin heads. So that's a distinction between the cause of each of these increased stroke volume occurring, all right? So norepinephrine is going to affect contractility because it increases the number of calcium channels that are open. Now, if you've done the PhysioX, all right, you probably remember working with some of the drugs that were associated with it, and calcium was an indirect factor of digitalis. Anybody remember what the effect was on digitalis? Was on the heart? What did it do to heart rate? Decreased heart rate, all right? And that's a result of both increasing the vagal nerve activity and decreasing sympathetic response to the heart, right? And that's at the autorhythmic cells. And then what did it do to stroke volume? It increased stroke volume, okay? How did it do that? It affected contractility. So digitalis affects the number of calcium ions available in the ventricular contractile cells, and it does so indirectly. And the reason I'm talking about this is because I alluded to it, but not very much, in talking about the think I mentioned it last week, but it was hard to remember whether I talked to you guys about it or the Monday, Wednesday group or both. So when the muscle cell in the ventricles contracts, or in a skeletal muscle cell, when it contracts, what triggers internally inside the cell, what changes inside the muscle cell triggers relaxation? Why does the skeletal muscle cell start to decrease the tension created during contraction? Pardon?
Calcium reactivity.
Right, calcium is removed because calcium is allowing the binding sites on actin to be available. Once we remove calcium, troponin and tropomyosin resume their positions and the binding sites are no longer available, at least not as many yet. Myosin can't bind to them, therefore myosin can't create a tension. So if we remove calcium ions from the muscle cell, then the muscle cell is relaxing. So calcium comes to the contractile muscle cells from two different venues. It comes from the sarcoplasmic reticulum, just like it does in skeletal muscle. But it also comes from calcium channels in the plasma membrane. And norepinephrine will open both of these, all right? That's how norepinephrine increases contractility, is by opening more of these calcium channels. So digitalis doesn't do that, all right? Digitalis works indirectly. What digitalis does is it blocks sodium potassium pumps. What does sodium potassium pumps do? We talked about them with our resting membrane potential. This is not affecting resting membrane potential in the way we're talking about it here, but what do they do? Which way do they move sodium and potassium? Sodium and, so we're using ATP. This is an energy source. So we're using ATP to do what? Move it down its gradient or up its gradient? Up. So sodium is high inside the cell or outside the cell? Outside the cell. So we need ATP to move sodium out of the cell, up its gradient, and we need to move potassium into the cell, which is also up its gradient. So if digitalis blocks the sodium pump from working, sodium is going to not be moved out of the cell. Sodium is going to gradually build up inside the cell. So that is the direct effect of digitalis on ventricular contractile cells. Okay, lay down the groundwork. Now, what does that have to do with calcium? All right, calcium is one of the methods by which calcium is removed from the cell, and there are two major ones. It has its own pump, calcium ATP pump, that will move it out of the cell. But another way is a SYM-port. And I don't know if you remember secondary active transport from Bio 430, but a SYM-port is when something comes into the cell and another molecule or ion comes with it. So sodium, remember, is moving down its gradient to come into the cell. So it's going to do that normally without energy. And what happens is actually an antiport. When sodium comes in, potassium goes out. This is a sodium ion exchanger. So sodium wants to move down its gradient to come into the cell, and that causes a protein exchange of sodium coming in down its normal gradient using its diffusion energy, and that moves calcium out. Okay? Well, if we have a lot of sodium in the cell, because our sodium potassium pump isn't moving, what happens to the gradient for sodium outside the cell versus sodium inside the cell? It's going to get less, right? Because there'll be a lot if we have no sodium inside the cell. So the more sodium that's inside the cell, the less difference there is between the two. So by digitalis blocking the sodium potassium pump, sodium is less likely to be pumped out. Therefore, sodium builds up. Therefore, less sodium is going to cross down its normal gradient because it's already in the cell. So if less sodium is coming in, then less calcium is leaving. Does that make sense? All right, so this is an exchange. The sodium comes down its gradient, exchanging calcium, which is then moved out. If we already have sodium in the cell, less sodium is going to diffuse in. Therefore, calcium is not going to diffuse out, and we're going to build up calcium ions in the cell. Which means that the sites are gonna stay exposed, or even this calcium is gonna get pumped back into the SR. So the next time the cell is stimulated to contract via an action potential, even more calcium will come out of the SR. So that's how digitalis causes the ventricular cell to contract harder, by increasing the amount of calcium available to the cell. It's an indirect, okay? Its direct effect is the sodium-potassium pump, but indirectly that leads to more calcium in the sarcoplasmic reticulum, because calcium is not being removed from the cell during relaxation. Okay? That was a long story, talked about norepinephrine. Okay, thyroid hormone, another name is thyroxine, or, any questions on that before I move on? I want to just kind of leave you in a gray haze there. All right, so thyroid hormone is unusual in that it's not a lipid-based molecule, but it's small enough to move into a cell. So it doesn't bind to a G protein coupled receptor. It actually is like a steroid hormone. It activates genes. And the genes that are activated increase the ATP activity of the cell. All right, so the mitochondria is making more ATP. Remember, we haven't talked about thyroid hormone yet, but if you know anything about hyperthyroidism, metabolic activity is increased. So, if we're making more ATP, we need more oxygen to do that. Oxygen is utilized in the mitochondria to make ATP. And if we need more oxygen in the body cells, we need a greater cycling of blood through the body and the lungs to do so. And so the body is triggered through several other subsets of activity I'm not going to hold it responsible for, to increase heart rate, solely for the purpose of getting oxygen to the cells faster, by increasing the cycling, decreasing the cycling time, increasing the movement of blood through the lungs and the body to get oxygen. Okay, sodium ions. We looked at the effect of dripping sodium ions onto the frog heart. So are we adding sodium ions directly into the cell, or are we increasing the extracellular concentration of sodium ions? The latter, all right? So we're increasing the extracellular concentration. The major thing here is it's going to inhibit the calcium ion transport into the cardiac contractile cells. So that means that it's going to obviously decrease the contractile force, but it also affects the intervals, as you saw from the PhysioX. It made the heart rate irregular. It created arrhythmias. Okay. So I'm not going to ask specific questions about this on the lecture exam, but on the lab exam, I may show you images the same as you saw for the lab report, and ask you, is this a sodium ion effect, or is this a potassium ion effect? So go back and review those lab report images if you don't have access to the PhysioX anymore. If you do, or you printed that off, you can view those directly. Okay? So there will be a few questions. Most of the questions obviously will be on ID structures of the heart and the blood vessels, straight anatomy, but the PhysioX lab is one of our labs, so there'll be a few questions, no more than 4, probably 2 or 3, from the physio out of the 54 questions from the PhysioX lab. Okay? A major thing on ions, though, that I want to show you is the potassium. That's the one that affects the membrane, resting membrane potential. And rather than memorizing this, I want to show you the next image, which is not on your slides because did I not save it? All right, let me pull it up here. I got a copy of one and I thought I saved it to the slides here. wasn't the exact image, but it's close to it. Here it is. Had it out first. So, usually potassium levels are not a clinical issue with the body because the kidneys are very able to moderate. If you have too low potassium or too high potassium, the kidneys will modify that pretty quickly. So it has to take an error in the IV or a specific intent to kill someone with an injection of potassium chloride. So normal levels are around 3 to 4 milliequivalents. We start to see changes around 7 or 8, and to see this kind of sine wave pattern, it takes about 11 to 12 milliequivalents. Okay, you don't need to know those numbers, but this is like 4 times the normal amount of potassium to see these changes. So what occurs is a flattening of the P wave. We're seeing very little atrial depolarization, and a peaking of the T wave. So it's decreasing the time that it takes for repolarization and almost dropping, cutting that off. And then eventually it gets to what we call a sine wave, because it looks like the sine wave from mathematics calculus. And so you see this deep trough here between the QRS wave and the T wave, and then finally that just eliminates the QRS component. And so it's this kind of S-shaped sinusoidal curve that we see with really, really extremely high. And what happened to the heart rate? You didn't see this when you dripped potassium on the frog heart, right? Why not? The answer has to do with one of the first couple of questions, second or third question on the lab report. No. What is when you did the physio-watts experiment, what was the oscilloscope showing you? Contractile force, and this is showing electrical current, okay? So it's hard, I mean, it's still oscilloscope, but it's oscillus tracing, so it's hard to remember that we're seeing atrial contractile force and then ventricular contractile force and then atrial contractile force and ventricular. We're not seeing the electrical current, so you're not seeing P waves and T waves, so you're not gonna see this kind of an image on the oscilloscope with the frog heart, because we're not measuring electrical current, all right? But you did see a slowing and eventual stoppage of the heart with that exchange of, with the addition of potassium, okay? But I want you to recognize this ECG change, okay? So essentially flattening of the P, peaking of the T, and probably more likely to see this than this, all right, as far as the, second one. As far as the flattening and slight peaking there. Okay, let's look a little bit at some pathologies before we move on to talk about blood vessel histology and start diagramming blood vessels. We've already talked about congestive heart failure. I just want to review it. Right-sided congestive heart failure is going to be more likely to result in systemic edema or pulmonary edema. Systemic, okay? So we back up the blood, when we think about congestive heart failure, to figure out where the loss of fluid across the capillaries is going to be, is to back up in the direction it's coming. So if the right ventricle is not weak, it's not strong enough to pump the blood to the lungs, then more blood is coming in than can go out, and that causes an increase of force in the right atrium, an increase of volume in the right atrium. That then backs up into the vena cavas, and then backs up into the blood vessels of the body and the capillaries around the body. And it's more likely to show up in the ankles first because of gravitational force on the fluid volume of the veins and capillaries. Okay, so right-sided congestive heart failure, systemic edema. If it's left-sided congestive heart failure, it can eventually become right-sided. It will back up from the left ventricle to the left atrium into the pulmonary veins. into the pulmonary capillaries, and across those capillary walls, we see fluid seeping into the alveoli. Then it will back into the pulmonary arteries and trunk, and into the right ventricle, and from there it can expand to congestive heart, to systemic edema as well. Okay, but the first one to occur for left-sided congestive heart failure is going to be the pulmonary edema, and systemic edema would be the right side. All right, so with congestive heart failure, two things are usually done to treat congestive heart failure. We want to decrease the fluid load on the heart, so it's not having to work as hard. So we would use a diuretic to cause fluid loss and limit the sodium intake if that's a problem for the individual. What's the second type of drug you think would be given to this person? Thinking of weakened left or right ventricle. What's the second type of drug that we would want to give? Something that's going to help the heart work stronger. So some kind of contractile, something that's going to enhance calcium, increase calcium in the myocardial muscles, and increase contractile force if the heart is already weakened, okay? So digitalis is actually an old-fashioned drug. It can cause more problems than it helps sometimes, but it helps to talk about it, helps to explain some of the functions of the heart with the sodium and calcium exchanger. But some kind of calcium enhancer, all right? To increase the amount of calcium ions in the blood is usually, in the heart wall, heart muscles is usually given for congestive heart failure. Now, what condition would you think of where a calcium channel blocker might be given? If we want to increase the amount of calcium ions in ventricular contractile muscle cells for congestive heart rate, what condition can you think of where a calcium channel blocker?
It's like when the valves don't close.
Stenosis?
Yeah.
That usually requires surgical treatment. It might be temporary, but hypertension. So a lot of times it's more common to not know the cause of hypertension, to not know what it's caused by. Sometimes you do, and you can address those causes. But most cases of hypertension, high blood pressure, the etiology, the specific cause is not known. And so we're trying to decrease the pressure load on the blood vessels. And we'll talk about this more on Monday when we talk about blood pressure. We want to decrease cardiac output if we can do so without compromising their oxygen distribution. So we would want to decrease contractile force, okay? And so calcium channel blockers are going to decrease the amount of calcium in the contractile cells and decrease the contractile force. All right, myocardial infarct is another name for a heart attack when there is actual tissue myocardial contractile muscle cell death. If it's just a lack of oxygen causing pain, that's ischemia leading to chest pain or angina pectoris. But we reserve the term MI, or myocardial infarct, to specifically loss of tissue. And if that is significant, it can obviously result in death because the heart is not going to be able to continue responding to action potentials, and the cells will not move the contract and move the blood through. This can be caused by loss of blood supply, so blood clot, all right? It's the most common cause, although some electrical events can be other causes. Anybody remember on the ECG what a common change in an ECG is that signals an MI? Back last week on Thursday when we were looking at the phases? No. It was an elevated ST segment, yeah. So an elevated ST segment is a common indicator of an MI. All right, so we're going to look at 2 or 3 conditions that can cause a cyanotic baby. So these are usually congenital, which means occurring during the developmental process of the baby is born with these. And the cyanosis is where the blue baby comes from. So they're not getting enough oxygen into their tissues, so they may have blue lips. They may turn cyanotic with exertion, like crying, or they may just be pale and cyanotic all the time. All right? So the first one is identified as a patent, which means open, ductus arteriosus. Now on Thursday, we'll be looking at fetal circulation. So we'll come back and talk about the ductus arteriosus some more, but I haven't mentioned it yet. And let me show you what the ductus arteriosus is. Its purpose is identical to the purpose of the foramen ovale. So remember, the foramen ovale allowed oxygenated blood, primarily, that was coming from the placenta and it passed through the liver, coming up through the inferior vena cava at a force that sent it up through the foramen ovale into the left atrium. So it bypassed the lung tissue. Lungs still need some oxygen, all right, but it doesn't need all the blood flow going there, and it would just take time. And the lungs aren't getting oxygen anyway during fetal life from breathing, so it would waste time. Superior vena cava sends only deoxygenated blood, and that tends to go primarily through the right atrioventricular valve into the right ventricle, but it will mix with some of the oxygenated blood coming from the inferior vena cava. Obviously, it's going to the lungs, and we need to get some oxygen there. It just won't have as much as what we find in the left atrium. So then that right ventricle is going to pump the blood out the pulmonary trunk, and it's going to go to the left and the right lungs. There's one more opportunity for blood to bypass the lungs. At this time in fetal development, the lungs are filled with fluid, and that causes a greater resistance to the heart pumping blood to the lungs than to the body. So it's harder for the right ventricle to pump blood to the lungs than it is for the left ventricle to pump blood to the body. So the ductus arteriosus is a small short channel between the left pulmonary artery and the aorta. When that is open, it's easier for the blood to flow into the aorta than to continue flowing to the left lung. And so a small amount will flow out of the pulmonary artery into the aorta. After birth, just like the phosphoballus, when the baby takes a breath and continues to breathe, pressure in the lungs drops precipitously when compared to pressure in the rest of the body, and therefore blood flow does not primarily preferentially go into the aorta. And so that will fill with collagen fibers and close similar to the foramen ovale. And so when it's closed, we call it a ligamentum arteriosum. We'll cover that on Thursday. But if it remains open, all right, it's not as significant as foramen ovale remaining open, but it is going to cause a deoxygenated blood now to be added to the aorta. So it's going to decrease the overall content of oxygen in the systemic aortic blood, all right? Enough that it can cause the fetus, or rather the newborn. This would probably be more with crying. It's not going to be a baby that's blue all the time because it's not a specifically large vessel that does that. All right, so septal defects can be either in the atria, so that would be a patent foramen ovale, okay? And that can stay open throughout adult life, all through childhood and into adult life. And it may not be something that someone is aware of. It may or may not cause a significant heart murmur, which may or may not be diagnosed. I had a friend who had a small stroke due to blood clots because when he was in his 70s, well, he's like 71 now, so he was in his early 60s, they discovered he had a patent foramen ovale because he had a stroke. I mean, it was so uncommon. I mean, I knew him when he was 28, 29. And so when I met up with him again on Facebook, and he said, well, excuse my typing, I had a PFO. I'm like, PFO? I had to go look it up because I wasn't associating a patent foramen ovale with somebody in their 60s. That's a newborn kind of thing, okay? But it can occur. Then a ventricular defect is seen here in the wall between the right and the left ventricles. And embryonically, there's two parts. There's called the membranous portion up here near the valve, and then a muscular portion. And this occurs because, remember I talked about how the walls grow together? So in the development of the heart fetally, these walls did not finish growing together, okay? And that allows blood to be shunted from the right side to the left side. Now, prior to birth, it's going to be shunted from right to left because remember, there's a greater resistance for the right ventricle pumping to the left. After birth, it's going to shift the other way. And we're going to send oxygenated blood back over to the right ventricle instead of out to the body. there's gonna be not so much a decrease in oxygenation as a decrease in the amount of blood going out. So the baby's heart rate is going to be increased. This is something that usually is not, it's going to require surgery, but they can wait a few days to weeks after birth, unless it's really a significantly large opening, and the baby is still getting enough oxygen to its tissues to survive until it gets older and stronger. Histology of Fallot means 4 things are wrong with the heart. Tetra referring to 4. All right, so these are the 4 things. Some of them are a result of others. So the ventricular septal defect, there's a hole in the wall between the right and the left ventricle, what we just talked about. More serious is the aorta is kind of in the middle. So when the right ventricle pumps and when the left ventricle pumps, blood from both ventricles goes into the aorta. So in this condition, we were sending oxygenated blood back to the lungs. The difference in this condition is the right ventricle is sending deoxygenated blood into the aorta because it's sitting over both the left and the right ventricles. When they contract, both oxygenated and deoxygenated blood go. To increase the likelihood of that, unfortunately, the pulmonary trunk is also narrow. Okay? And so that makes it more likely that blood goes in this direction. And the last one is more of a side effect of this, because since the right ventricle is sending blood into the aorta, that's a greater resistance, and so the right ventricular wall gets thicker because it's having to work harder to push blood into the aorta rather than into the pulmonary trunk. So we tend to see a thickening of the right ventricle compared to its normal amount of muscular development. So with the addition of deoxygenated blood, the person's not getting the amount of oxygen in their tissues as they normally would. All right, then we have not just an overriding, but a complete flipping. The aorta now comes out of the right ventricle, and the pulmonary trunk comes out of the left ventricle. So if we follow this through, we have the right ventricle, instead of pumping blood to the lungs, pumps it into the aorta, which goes to the body, comes back into the right atrium, and gets pumped to the body again. The pulmonary trunk, being pumped by the left ventricle, pumps to the lungs, comes back to the left atrium from the lungs, into the left ventricle, and gets pumped to the lungs again. In this case, the ventricular septal defect saves this baby's life. All right, because after birth, at least it's only the mixing of blood allowed because of this and maybe a patent foramen ovale that allows any oxygenated blood to get into the aorta. So the left ventricle is sending blood through the septal defect up the aorta, and the right ventricle is sending blood through the septal defect to the lungs, and so we're getting a mixture of blood. It's not very well oxygenated, but it's that ventricular septal defect that's allowing any oxygenated blood to get to the tissues. Okay? And I mentioned last night, and I mentioned to you guys when we were first talking about the heart at least, that an older student had brought her son to class. He was born about 15 or 18 years ago. Actually, he came about 15 or 18 years ago. He was probably born about 30 years ago. With this transposition of the great vessels, but he had no septal defect. So when he was born, there was not going to be any mixing of the blood. Blood went to the lungs, into the heart, into the lungs, into the heart. Blood went to the body, into the heart, into the body, into the heart. And the only allowing a mixture of blood during fetal development was the foramen ovale. So fortunately, with ultrasound, and not all babies back then got ultrasound very frequently, this was known before he was born, and surgery was set up, and he was in surgery within minutes of being born. Okay? And it took several surgeries first of all, they just created a septal defect, and then it took several surgeries to switch the vessels. He also had a narrowed pulmonary trunk. Okay? But he was 15 when he came to visit the class, and he was too shy to talk, so his mom kind of explained what his surgeries, and then I explained to the class. Instead of his circulation being like this, he had 2 complete separate circulatory cycles. Okay. So let's switch interval was one of the things that you were asked to measure on the ECG, on that very first question. So the PR interval starts with the beginning of the P wave and ends with the beginning of the QRS wave. It's really a PQ interval, but it's called the PR. So during that time, which of these things are occurring with the valves of the heart? Okay? So during the P wave, but before the QRS wave starts. There's going to be at least two answers, so you have to talk about the position of the AV valves, and you need to mark the position of the semilunar valve. There's going to be two answers that you're going to choose, one for AV and one for semilunar. If you're not sure what's going on, look at your diagram of the cardiac cycle associated with the big diagram, the big page diagram that showed the cardiac cycle with the pressure changes in the aorta and the atria and the ventricular pressure, and associated with ECG. So remember we talked about 3 events, 4, but one of them was the same. So we had ventricular filling, we had ventricular ejection, and before and after ventricular ejection we had isovolumetric. So we had ventricular filling, and then we had isovolumetric contraction, ventricular ejection, and isovolumetric relaxation before we started with ventricular filling again. So to answer this question, you kind of need to figure out which of those is occurring during the PR or PQ interval, okay? Is it filling, is it ejection, or are we in the isovolumetric stage, which is a very, very short period of time, okay?
You're including the P wave, right?
Yes, the beginning of the P wave. We're talking about this time period, okay? So for most of this time period, what's the position of those valves? Okay? Without giving you the answer, is it going to be ventricular filling, ventricular ejection, or isovolumetric, something or other? So what has to occur for ventricular filling? The ventricles are relaxed, okay? Can the atria contract during ventricular filling? Yes, as long as the AV valves are open, the ventricles can, the atria can contract, all right? For isovolumetric contraction, what has to happen? the ventricles have to contract enough to cause the AV valves to close, right? What valves are open during ventricular filling? AV valves. What valves are closed? Semilunar. So those are already closed. When we start isovolumetric contraction, isovolumetric contraction, the ventricles have to contract enough to create the pressure force to close the AV valve. That's the beginning of isovolumetric contraction. So the ventricles have to have already started to contract. When ventricles contract, that occurs as a result of what that we see here. QRS. QRS is showing depolarization of the ventricles. That's why they contract. So prior to that, the ventricles aren't contracting. All right, so of the four events I talked about, ventricular filling, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, at which time are the ventricles never contracted? During filling, okay? Because isovolumetric relaxation is going to be when the ventricles are starting to relax. They've already contracted. They're starting to relax, and that occurs as a result of T waves. It's during the T wave that the ventricles are relaxing, okay? So what I'm trying to model here is how you can use the information that you have to figure out what you think you may not know. All right, just kind of, okay, what's happening here, why, when does this happen? So not asking you to come up with new information, but to use the concepts you already have to say, okay, what else is happening at the same time? All right, so looking at our blood vessels, I kind of written out in a linear form here. The vessels that the blood travels through, and remember why blood flows. Why does blood flow? It's moving from a region of high pressure to a region of low pressure, okay? And it's the ventricular contraction that starts that high pressure, all right? So the vessel with the highest pressure, and again we'll review this on Tuesday, we have the heart. So the aorta is going to have the highest pressure. Otherwise, blood's not going to go uphill. We have some other region past that that has higher pressure. Okay, so it'll be blocked. So we have the artery. Blood flow then goes into multiple arterioles and even more capillaries. And then the capillaries start to join back together again to form postcapillary venules. Those join to form a few less venules and then fewer veins, and finally two vena cava. Okay, so we leave the heart up via the aorta, also the pulmonary trunk, but we're just looking at systemic circulation, and it returns to the heart via the two vena cavas. The sum, if we do a cross section of the volume of the aorta, so here is, without necessarily being exactly the same, here's the aorta, and if we look at the volume of that vessel, and we look at the volume of the two vena cavas, would the aorta be the same, more, or less than the sum of the volume of the two vena cavas? The same. Otherwise, remember we have to have the same volume going out as we have coming back in, or we get into congestive heart failure. Okay? So anytime we do a cross section, so the sum of the volume of all of the arterioles is going to be equal to the volume of the aorta. The sum of the volume in all the capillaries is going to be equal to the single volume of the aorta. Okay? When we look at blood pressure on Tuesday, however, when we go from one vessel to a whole bunch of smaller vessels, even though the volume might be the same, what has happened to the total surface area? It is increased, which is going to increase our resistance. Okay? We're going to come back and visit resistance, peripheral resistance of our blood vessels, and how that affects blood pressure. For now, we're just looking at the structure. So, arteries are called arteries because they're under high pressure, whether they're carrying oxygen or not. And veins are returning blood to the heart, so they are under low pressure. Okay? Now, we're going to look at the histology, some characteristic histology of each of these. The vessels closest to the heart have, well, all of them are, except for the capillaries and the postcapillary venules, are gonna have the same 3 layers, just like in the heart, we have endocardium and myocardium and pericardium. We had a lining layer, a muscular layer, and an outer covering layer. We see those same 3 layers in most of the blood vessels. So the lining layer is known as the tunica intima. The muscle layer is known as the tunica media, meaning the middle layer. And the connective tissue covering layer that helps to hold it in place amongst the other tissues is known as the tunica externa or adventitia. Those 2 names are exchangeable. Okay? So I'll diagram the histology of these with you, but I want to give some characteristic facts about each of these where I have them in one location. So elastic arteries are also known as conducting arteries. Okay? And they're going to have characteristic sheets of elastic fibers in their tunica media. Because they're so close to the heart, they're under the highest pressure, and this additional amount of elastic helps them to return to their original size, and it helps to keep the blood moving away from the heart. Muscular arteries are also known as distributing arteries. And they're going to be the 1 or 2 downstream branches off of the aorta. Okay? Farther away from the heart, or if they're close to the heart, they're going to be a 2nd or 3rd branch off of the aorta, where the pressure has decreased. They are going to have a few fibers of elastic in the tunica media, but they're not going to have sheets. All right? So these are characterized primarily by a structure known as the internal elastic lamina. And I'll note that for you when we diagram it. It's part of the tunica intima. Arterioles. We're going to talk about this again on Thursday. These are the major vessel that helps regulate blood pressure. Right? In fact, arterioles are known as the pressure reservoir. Now, the reason why, there's more capillaries, all right? So you would think that they would be more significant in their constriction and dilation, except capillaries have no tunica media. So this is the most numerous vessel that actually has smooth muscle in its wall and can constrict and dilate. And so it has the greatest effect of changing peripheral resistance. If all we have was one vessel, the aorta, all right, and the aorta changes diameter from that to that, we're not changing the surface area quite as much as if we had 1,000 of those decreasing their diameter. So that's much more effective in decreasing or increasing the amount of surface area. So because arterioles, we have lots of arterioles. We have even more capillaries, but the capillaries don't have any muscle, so they're not able to constrict or to dilate. Also, with capillaries, by definition, they have 1 to 2 layers of smooth muscle cells. If you see in the tunica media, if you see a vessel that has no smooth muscle, it's going to be a capillary or a venule. If it has more than 2 layers, it's going to be an artery. Okay? So 1 to 2 layers of smooth muscle is our artery. Capillaries. This is where we have diffusion of gases and nutrients and waste. And it's because it has a tunica intima, and that's short distance, which is necessary for diffusion. With muscle there, that makes the diffusion distance too great and it's not very effective. Okay, post-capillary venules are venules that are right after the capillaries, just like its name says. And venules are like large capillaries without muscle. So about the only way you can distinguish between a capillary and a venule is the number of red blood cells inside it. All right? A capillary is going to be just barely large enough for a single red blood cell. So they have to travel in single file. And that slows down the blood flow and gives greater time for oxygen to move out and carbon dioxide to move in. If we're looking at a venule, it's not going to have any smooth muscle either, but it's going to be larger and will have numerous red blood cells in it, okay? Now, the significance of a post-capillary venule is this is where diapedesis occurs. Anybody remember from Bio 430, discussion of inflammatory processes, wound healing, what diapedesis is? The best way to explain it is to draw a picture. Here's our post-capillary venule, which means it's the vessel right after a capillary, and that's a white blood cell, like a neutrophil, okay, or a basophil. So when we have an infection, a cut, whatever, introduction of pathogens to the tissue, the white blood cells that are already there will release chemicals that have a constant chemical gradient, and that attracts further additional white blood cells to the area. Chemicals like histamine or heparin will increase the permeability of these vessels, and diapedesis is the cell shape change that these vessels undergo to squeeze out of those openings between the simple squamous epithelia. So that process of the white blood cells leaving the blood vessels to get to a site of infection occurs primarily in the post-capillary venules, not the capillary structure, but immediately after. All right, the only other comment I want to make about veins is they have a very thin tunica media because they are under low pressure, and most of them have valves. Okay. Not all veins will have valves. The veins in your face, right around your nose and your nasal cavity do not. But most do. So those are the key functional or structural characteristics I want you to know about each of those vessels. And then we'll look at some histology, okay? Kind of look at the changes that occur with the wall for each.
Difference between post-capillary, venule, and venule?
Is size.
Just size?
Yeah.
They're other than that, they.
I'm not going to ask you to distinguish
Okay.
between them for histology.
Okay.
We'll show you a picture to say which one is post-capillary, which one is actually a venule. Okay? All right, we're not going to say anything about lymphatics because that comes in our next unit, and we'll come back to that. But just for now, remember, cap fluid can cross the capillaries. Some of it will return, but not all of it. So if that was all we did, every time we had blood circulating through the body, you had an increased fluid in the connective tissue, and you would gradually swell. So that additional fluid that's not returning to the cardiovascular system is returned via the lymphatics. However, the way they are structured to accept that additional fluid is other stuff can enter into the capillaries too, like bacteria and viruses, and if they're present, metastatic tumor cells. So before we dump all that stuff back into the blood, we send it through lymph nodes, which are highly concentrated structures of macrophages and lymphocytes. And it's a series of filtration so that we get any of that foreign material out of the fluid before we add it back to the cardiovascular system. So So we'll look at that when we start our next unit, or get into after we pass the blood cells. All right, so let's take a look at some of the histology for our vessels. You can see right off at the beginning here, the difference between artery and a vein due to the pressure is the thickness of the wall versus the lumen of the vessel. So a large lumen vein is going to have a very thin wall, whereas a small lumen artery is going to have a very thick wall because of the proportionate higher amount of pressure. And the major component that changes in thickness is the tunica media, okay? The amount of muscle that is present. And here's another, this happens to be a muscular artery, all right? You can't see the internal elastic lamina there, but I'll show some additional images. So here is an elastic artery. And I got some additional pictures that I didn't use last night, Katie. I don't know if you can see in the back, but these dark pink lines that you see here, layer after layer after layer, those here are the elastic sheets. Normally we stain them black or blue, and here they're still pink, but they're almost, it seems like there's more than the smooth muscle cells. So this is an elastic artery like the aorta, or the subclavian artery that branches off of the aorta, very close to the heart under high pressure. So it's going to have a very thick tunica media, but it's also going to have lots of elastic fibers. So I'm going to leave that up on the board while I diagram it. May I erase what's on the board now? Let's have that. So epithelium is going to be blue, connective tissue is going to be green, collagen fibers, and smooth muscle will be red. All right. So here we have the simple squamous epithelium, which is continuous with the endocardium of the heart. And that provides a smoothness to the lining of the vessel. When we talk about blood coagulation, hemostasis, that's going to change, and that change allowing some of the collagen fibers to be exposed can trigger clotting events. So as we have under every epithelium, this has a loose irregular connective tissue. And that is our tunica intima, okay?
What was the smooth or simple squamous continuously?
The heart, the endocardium of the heart. Then the tunica media is a circular arrangement of smooth muscle cells. And it's going to be quite large in diameter for our larger arteries because of their higher pressure. Compared to the lumen of our vessel, okay? For an elastic artery, and I'm going to do this in black because the elastic sheets were stained, we're going to see sheets of elastic, not just elastic fibers, but whole sheets of elastic fibers interspersed with layers of smooth muscle in the tunica media, right? These are known as elastic sheets or layers or sheets, which would be lamina. So that whole layer is our tunica media.
So the elastic
would be the elastic, the red would be the smooth muscle. Okay. And then the amount would be depending on the size of the vessel, but out here, we would have loose irregular connective tissue. The larger the vessel, the more likely that there would also be dense irregular, at least part of it. So loose, the dense. Irregular connective tissue. And that would be the tunica externa, or as some books have, tunica adventitia. So, multiple layers of smooth muscle with intervening sheets of elastic fibers. Yeah?
Just making sure the tunica externa is the loose connective tissue that could be done.
Yeah, it's the loose, so just outside the tunica media, we have collagen fibers arranged irregularly. That's the loose or dense irregular connective tissue. The larger the vessel, the more likely that some of it's gonna be dense irregular. Which is a small artery, it's gonna be just loose. Okay. So, right up here at the very top, you can see a few little dots. And that's the simple squamous epithelia nuclei of the tunica intima. Then all of this is tunica media. And then out here would be the tunica adventitia, tunica externa. Okay. All right, now let's look at the muscular arteries. Remember the unique structural component I wrote on the board in blue for the muscular arteries? The presence of elastic, but seen as a single sheet, and that's the internal elastic lamina. So this red line that you see here, which is a part of the tunica intima, throws the lining of the muscular arteries into these, looks like corrugated metal, sheet metal, okay? And that's due to this internal elastic lamina. There are a few, you can see some little wiggly lines here. Those are elastic fibers, but we don't have the amount of elastic sheets. And it's hard to pick out. There's also an external elastic lamina out here, but I'm not gonna tag that, so I didn't bother writing it on the board, but it kind of encompasses the tunica media. But this internal elastic lamina is actually a part of the tunica intima. All right, so let me diagram that. May I erase the board? Okay. So we're going to have a lot more muscular arteries than we do elastic arteries. They're going to be smaller in diameter. Although I'm not going to keep the diameter here proportionate, because then the capillary is going to be really, really tiny, and I'm not going to do as much good to draw. Actually, let me draw this again. Left out the corrugated appearance. Again, simple squamous epithelia. Loose irregular connective tissue. And then the internal elastic lamina. Which is usually looks like it's just deep to the epithelium because it's hard to, there's internal. And it's that elasticity that creates a corrugated look. So these three components now form the tunica intima. The internal elastic lamina is part of our tunica intima. Tunica media is still going to be much thicker for the diameter, the lumen of the artery compared to a vein of the same size. This is smooth muscle that I'm drawing. All right, and there might be some scattered elastic fibers, but not the sheets, okay? So this would be smooth muscle. And then this would be our tunica media. And then the tunica externa is going to be exactly the same, okay? Loose to dense, irregular connected. More likely to be loose than the elastic artery. Now, one thing I want to mention before we leave the tunica media as we move into the capillaries is the arrangement of the smooth muscle cells, because they're coiling around the diameter of the arteries in a pretty tight coil. All right, especially in the arterioles, as that gives them a greater force in their contractions. So on the arterial side of the capillaries, we're going to see smooth muscle cells wrapping around the arteries in this fashion. We still have smooth muscle in our veins, but the spiral is much more loose. So even when a vein does contract, not only is the tunica media thinner, but when the smooth muscles contract, they're more of a vertical arrangement, so they're not going to be able to decrease the diameter of the veins quite as much. Okay. So on this image, starting with the internal elastic lamina and going out here, and again it's pretty thin, that would be our tunica intima. Starting here, these would be our smooth muscle cells with some elastic fibers. This would be our tunica media. And out here would be the tunica externa. All right, so this is a longitudinal section of an arteriole. And endothelial cell is just another name for the simple squamous epithelium specifically lining blood vessels, like endocardium. So this arteriole has only one layer of smooth muscle cells. Now, I don't know if you remember, I didn't talk a lot about hardly at all about smooth muscle cells in Bio 430, but smooth muscle cells are shaped, tapered at the end and wide in the middle where a single nucleus is. So if we cut a smooth muscle cell anywhere along there, we could get a different profile. It's kind of like cutting a hard-boiled egg. You might not get any yolk in your slice or the hard-boiled egg, all right? or you might get a little, tiny little circle if you're just grazing the yolk, or you might get a great big circle. So if you think of that hard-boiled egg as a smooth muscle cell, it's gonna be different sizes, different diameters, depending on where we cut it, whether it's the tapered region or the thick region. We may or may not have a nucleus in it. So here you can see that some of the nuclei are large, some of them are very small, all right? This cell here, or these cells here have no nuclei at all, just in the image, because of where the cell was cut as it's wrapping around the arteriole in this direction. So the smooth muscle cells are wrapping around the vessel like this. They're not running the length of it, okay? Whereas if we cut an arteriole in cross-section, then we can see the smooth muscle cells in their entirety with the larger nucleus, okay? So may I erase the board for the artery components? So in a cross-section, we're still gonna have the simple squamous epithelium. Still gonna have a little bit of loose irregular connective tissue. And 1 to 2 layers of smooth muscle, okay? Again, if it has none, it's probably a venule, okay? If it has more, it's classified as a small artery, and then of course we would have our tunica externa. Okay? In a longitudinal section, it would be our simple squamous epithelium. And then it would be cutting the smooth muscle cells this direction, okay? Because you're wrapping around. So we would have small ones and large pieces, and depending on where in that cell we cut it, but again, only these would have nuclei. We have enough smooth muscle to affect the diameter and change peripheral resistance. What you're seeing down here are fibroblasts, not smooth muscle cells. These are muscle cells. All right, so as we move into capillaries, we're going to keep just the tunica intima. We're going to keep just the simple squamous epithelia, no muscle at all, and we're going to have a smaller diameter. All right? So here in these arterioles, there's a couple of red blood cells there, red blood cells here. When we get to a capillary, it's going to be just large enough for a red blood cell. But here's only question number 2. So identify this blood vessel, which just saw it a few moments ago. So we have a lab quiz on Thursday, and most of the questions will be from vessels we're identifying, but one question will be like this. I'll show you a blood vessel, histology of a blood vessel, and ask you to identify it. Okay? I will not have post-capillary venules or venules up there, because it's too hard, but I might have a vein or the different types of arteries in the cap. We'll turn from that choice. May I raise the board? We're going to go through the arteries of the pelvis, so head to pelvis, and we'll do the lower extremities with the veins on Thursday. So those, the vessels of the lower limbs will not be on the quiz, and I'll give you as well some time to study on Thursday before we have a quiz. All right, so here's an image that has capillaries and a venule. This is not a post-capillary venule, all right? But you can tell it's not a vein because it has no muscle. So it has a very thin wall, just capillaries, without much muscle. This is connective tissue out here. Here's another smaller venule. Here's an arteriole, which is one layer of smooth muscle. And here are capillaries. Notice this capillary has only one red blood cell in it. Okay? When we get to the lymphatic system, another vessel this could be is a lymphatic. So for instance, here's a vessel that has nothing in it. It's a white blood cell. But since this has red blood cells, I know it's not a lymphatic because red blood cells, unless there's a bleed, do not leave the cardiovascular system. White blood cells do. So this had only white blood cells in it, okay? It would probably be what we call a lymphatic that we'll talk about in our next unit. The presence of red blood cells says it can't be a lymphatic because we never have red blood cells in those, the only tissue fluid in those particular vessels. All right, so looking at a capillary, as far as the epithelium is concerned, we have one, at the most maybe two simple squamous cells forming a capillary, okay? And to give you an estimate of the size, just slightly larger than the size of a red blood cell, okay? Which are about 7 microns, 7 to 7.5 microns. With a little bit of connective tissue. Okay. Now, there are 3 different types of capillaries based on a couple of things. The coverage of basement membrane, where every epithelial cell has basement membrane that it rests on. So if the capillary is completely surrounded by basement membrane, which I'll illustrate with purple. All right, so if the basement membrane is not patchy, it's continuous, that gives us our continuous type of a capillary, okay? If, however, the basement membrane is in patches, it's considered to be discontinuous. It makes it easier in the bone marrow for red blood cells and white blood cells to move into the blood vessels of the bone marrow if the basement membrane is not complete. Alright. Then the other type of capillary we have has to do not with the basement membrane, but with the fact that the capillary membrane may have pores. And we call those pores fenestrae or fenestra. So these capillaries are identified as fenestrae. And we'll talk about those when we get to the kidneys, because that provides the filtration membrane, separation based on size. So here's an illustration. Here the basement membrane is completely all the way around. That would be continuous. Down here, the basement membrane is discontinuous, so it's patchy. There's parts of the epithelial cells that are not associated with the basement membrane. And here the epithelial cells have pores. So if we're in the kidney, amino acids, sodium ions, and so on could pass through, glucose molecules could pass through, but whole proteins could not, right? So here's a discontinuous cell that also has pores, and that's similar to what we see in the bone marrow.
Where are the pores?
See these little holes?
They're in the.
They're passing through. So if we were to look at the simple squamous epithelia, probably the easiest way I have to describe this, if you were to have a cell, a simple squamous epithelial cell, and then you were to take a hole puncher and punch a hole in it, and the edges of the membrane were sealed where we punched that hole, that would be a fenestra or a pore.
Is it through the basement membrane as well, or just the?
It depends.
Okay.
In the bottom one it is, and this one it's not. So in the kidneys, they're not. We have a continuous basement membrane in the kidneys. But you don't have to worry about where these are found. We're going to talk about them when we talk about the organs that have those systems. I just want you to know about what the definition, what that means. Okay? All right, so now we're moving on the other side of the capillary. We're moving blood now, not away from the heart, but towards the heart. Of course, as soon as we leave the heart, we're actually moving back towards the heart, okay? But we've crossed the capillary system and we're moving back to the heart, so blood pressure is even less. So here's a good image illustrating the thickness of the wall of the tunica media, of a artery versus a vein, okay? Under much, much lower pressure, so fewer smooth muscle cells. I'm not going to diagram it on the board because it's going to be the same structures. Same tunica intima, smooth muscle like we saw with our typical structure over the artery without the internal elastic lamina. But this would be the tunica externa out here, and it's this layer right here, which is the tunica media. You can see it's rather thin. Another thing that veins have are valves. All right, so if this happened to be captured where two valve leaflets were shown within the vessel. And because veins carry blood under low pressure, this helps them move against gravitational force. And we talked about venous return with the effect of skeletal muscle. We'll talk about an extra pump. So as these are deep veins, superficial veins in your skin are not going to be as affected by that, although they also have valves. So when the skeletal muscle contracts, it squeezes the veins, and that would move blood this way, which closes the valves. And now the only way the blood can move is towards the heart because of the orientation of the valves, or like the cylinder valves. So increased pressure to force them open. Sometimes those valves weaken as the vessel walls weaken and they stretch apart. When this is seen in the skin, it's known as varicose veins. And this can be due to genetic weakness of the valves, which is going to occur even with typical usage. But it can be increased by people who are on their fetal day, like teachers, all right, or nurses. And again, because of gravitational force, causing increased pooling of fluid in the lower extremities, and that stretches open those valves. Now, my right thigh, I have about a 10-inch expanse of varicose veins right there that all started because I wore a pair of shorts which were too tight. After my son was born, my husband was not an extensive bicycler, but he had bought some cycling pants that were too small for him, with the padded bottoms and everything. And although he would be caught dead now wearing padded bottoms, but he was going to mail them off to a friend. And I said, oh, I'll wear them. When I take Chris out in the jogger for a run, I was running about 46 miles a day. I said, I can wear those. So I put them on, and I was, starting my exercise program. And about 2 months down the road, I got out of the shower, and we had double mirrored glass doors, and I looked in the mirror and I had this long vein that had not been visible before, and all of a sudden now was visible, and I could actually feel where it caused my skin to bulge out, and it disappeared right there. And I was like, where in the world did that come from? And it wasn't until a couple days later when I was pulling on those shorts that I realized that the vein disappeared right at the edge of the shorts. So compression sleeves are great if they don't cut off the blood supply. So what I was doing was exercising, using my skeletal muscle pumps, pushing more blood back, and then I had this tight band of these Lycra shorts that wasn't letting the blood through as much as it was being pumped back up and causing it to back up and stretch those valves out. So my son is now 28, and in the back of my mind, I've always wanted to go through and get those stripped out. It's not supposed to be covered by insurance because they're a cosmetic thing, although the woman that I've been staying with for the last 3 years or so since we bought our house in Colorado had it done on her insurance because it was becoming painful. Because I could always tell my doctor it hurt, but happy yet. She had both legs done 3 days before Thanksgiving, and then she had company for Thanksgiving. She was out of it, under the effect of pain meds. She's not very happy with it. I've asked her a few times why she's not happy, and she won't talk about it, so I don't know. And she wears long pants all the time, so I haven't had a chance. She had spider veins though, and I don't have spider veins, so it's kind of, I don't think it affected the spider veins. So some people have these a lot more without any specific cause, just because of genetic weakness of the valves. I've heard that you can increase the strength by eating pansy leaves, maybe nasturtium leaves. Like I told the class last night, I don't know how many cups of pansy leaves you would have to eat every day for that to occur. They can be removed. They used to be just stripped out. Then caustic chemicals were injected in that caused them to collapse. And now they're caused to collapse with lasers. So they're not taken out, but they're not visible, and they're flattened because there's no blood flowing through them. Okay? I did talk to my OBGYN a long time ago about doing it. He said, well, it was before when the twins were born. He said, well, you're just going to get more if you have more kids. They're now 23. So maybe one of these days, when I'm 90, I'll get my varicose veins on my right leg taken care of, right thigh. Okay, so let's stop there. And when we come back, we'll start diagramming blood vessels. We're going to follow them away from the heart, all right? And so why don't you guys come back at 15 minutes, so 20 after. And we'll start with the order.